I'm depressed. It's cold, it's wet, it's dreary, it's miserable. It's Portland in February. It's still the greatest place to live, but yeah, it can be depressing. This has been a year without any summer, but pus keeps flowing. And because of pus, we have the Persiflager's Puscast. Ooh, how's that for a segue? A review of the infectious disease literature. This is covering the first 15 days of February 2012. This is brought to you by Pusware LLC, the publisher of the Infectious Disease Compendium, a Persiflager's guide, available online and as an iPhone app. I'm currently working on the Android app. It'll be available sometime before I die. As always, I have no conflicts of interest, and if you're interested, the references are available on the website. You can go to my growing multimedia empire at moremark.squarespace.com. You can buy my book, Pus Whisperer, on Amazon. And hey, you can even write me a glowing review on iTunes because my ravenous yet fragile ego demands it. So, let's move on to the literature for a little bit. I try and make this a clinically relevant podcast and focus on treatments, diagnosis, or pathophysiology. I would point, however, to the New England Journal of Medicine this month has a great editorial called The Perpetual Challenge of Infectious Diseases, which goes through sort of the history of infectious diseases. And it starts off in the second paragraph with, infections have distinct characteristics that, when considered together, set them apart from other diseases. And they go through all the different aspects of infectious diseases in history and what continue to make infectious diseases the most interesting and endlessly fascinating part of internal medicine, or in fact, medicine altogether. I know virtually everybody subscribes to the New England Journal of Medicine, so I would suggest you pick up your own copy and read it. It's worth your while. This can be filed under Amazing, a report in the MMWR of an 8-year-old girl who got rabies and survived with only supportive care. She received no rabies medications or prophylaxis. The presumptive source of her rabies was cats. There were rabid cats in the neighborhood. And it's further evidence that if you have not immunized your cats, you should at least have them autoclaved. Her treatment was supportive and consisted of ketamine, midazolam, amantadine, and nimodipine, all to prevent cerebral artery vasospasm, as well as fluorocortisone and hypertonic saline to keep her sodium level up. Then she was put into a coma and supported. And she got better with evidently no long-term neurologic sequelae. This is now the third person to survive rabies in the United States with aggressive supportive neurologic care. Unusual, to be sure, but still interesting and something to be considered in someone who has a progressive encephalitis, especially if they have a flaccid paralysis. So I did the last entry yesterday in Portland, Oregon. Then I came down to the Oregon coast for the 3-day weekend, and there was a bat yet again in the living room. And then I went to get something to catch it, and it disappeared. So there's a bat loose somewhere in the house, and I'll be damned if I know where bats go to hide. Ugh. My son wouldn't stay the night. He went and stayed with his grandma because of the bat in the house, but I'm going to catch the damn thing and do an Ozzy Osbourne. No, not really. I don't want to get rabies. Transmissibility of infections is always of interest, especially diseases that can kill you, like, say, HIV. This study looked at serodiscordant couples in Africa, and here's what they found. From a single transmission, male to female, the risk was 0.0019. And the risk of female to male was 0.001. So about a 1 in 1,000 chance, if I read this right, of getting HIV from a single sexual contact, plus or minus the error. So it's not a very infectious disease, although I have noted that people do tend to have risk behaviors in repetitive ways. Other interesting thing is that as your viral load went up a log, your risk of transmission went up threefold, but the use of condoms decreased it about 80%. Other things which didn't surprise me were that HSV, genital ulcers, and vaginitis increase the risk of HIV, and male circumcision decreases the risk of HIV. So if you're planning on having sex with an HIV-positive human in the near future, have a circumcision, wear a condom, and don't have herpes, and have your viral load suppressed. I'm going to be totally distracted. I'm going to keep looking for that damn bat as I do this. So if I seem a little unfocused today, I have bats in my belfry. As they point out, however, in the accompanying editorial, that 1 to 2 transmissions per 1,000 coital acts is pretty low to account for the explosive growth of HIV in Africa. And there have been models to suggest that the vast majority of spread of HIV is done during the acute infection and the months after that, when you have the highest viral load, yet people remain sexually active. As long as we're on the topic of bats, which I know we're not, but that's all I'm going to think about during this podcast, is actually HIV. Let's talk about immune reconstitution syndrome, shall we? As you probably know, when patients' immune system recuperates in the face of highly active antiretroviral therapy. I used to call it fairly active antiretroviral therapy in the old days, but FART just wasn't the acronym that people liked. So when people are on their heart, they get a reconstitution of the immune system, and then they can become symptomatic for a variety of infections. And this study went back and looked at all the iris in their AIDS patients. They found it was remarkably common, and it depended in part upon what disease they had. It occurred overall in more than 10% of patients, but it was most common with Kaposi's, where 30% had iris, then tuberculosis, where 16% had it, followed by Cryptococcus at 14, MAI at 10, and only 4% had a problem with pneumocystis. Also, patients tended to have more mortality and morbidity if they had visceral KS. So, not all irises are the same. But both an ophthalmologist and a horticulturist could tell you that. And while circumcision does decrease the chance of a male acquiring both HSV and HIV, in a study out of Africa that looked at transmission from male to female in circumcised versus uncircumcised men, circumcision afforded no protection for the transmission of HSV2 to female partners. Not a surprise. If you want to have fun, you should go to Science Based Medicine and read the comments in Harriet Hall's essays on circumcision. There's some really interesting people that have strong opinions about circumcision out there. As I've said before, there are things that mark me as old and justify my carrying an AARP card. I don't understand visible underwear. I don't understand those ugly square plastic glasses. I don't understand hip-hop. I don't get tattoos and why people have tattoos. But if you're going to get a tattoo, the CDC recommends that you have a professional do it. The reason is that if you have an amateur do it, as they say in the article, friends, family members, and prison cellmates, it increases your risk of hepatitis C. Somehow I think if you're in prison, you don't have a lot of options as to who's going to give you your tattoos, but homemade tattoos are a risk for hep C. Not really a surprise, but if you're going to participate in behaviors that baffle and confuse old men, do it with a professional. H1N1 was, as flu pandemics go, relatively mild. It's estimated that there were 60 million cases, 274,000 hospitalizations, and here comes the quotes, only, in quotes, 12,000 deaths. It was actually a fairly mild outbreak as influenza goes, and the question is why. And this study in CID looked at this issue and found that there was actually a lot of pre-existing immunity to the H1N1 strain, both from prior vaccinations and from prior exposure to H1N1 antigens. The immunology of influenza is not straightforward, and the antibodies can have varying degrees of cross-reactivity with different H1s and different N1s in the vaccine, so that it is estimated that there was a significant amount of immunity in the population that ameliorated the symptoms of influenza, despite the fact that it had an infection frequency rate of around 23%. So that even though you might have low specific antibody titers against the influenza, you still have immunity to other antigens of the virus and can respond. As the article says, quote, presence of heterologous immunity in the absence of detectable serum antibody to epidemic virus has been previously shown in this and other studies. And if you're lucky enough, you'll develop antibody against a universal epitope on the virus and have immunity against all influenza strains, which is currently the holy grail of influenza vaccination. But it's not as simple as one vaccine equals one immunity to one antigen when it comes to influenza. Those of you who participate in my growing multimedia empire know that I write a blog entry every October entitled A Budget of Dumbasses. It's about the fact that if you're a healthcare worker and you don't get a flu vaccine, you are a dumbass. Why are you a dumbass? Well, go read the essay. But this study particularly looks at the effectiveness of influenza vaccine in preventing hospital-acquired influenza in patients. This was a case-control trial, not a prospective randomized trial. But they found that when influenza vaccination rates in the healthcare providers went above about 35%, that the amount of hospital-acquired influenza decreased in the hospital. So that having at least 35% influenza vaccination had a shielding effect on the acquisition of influenza in the hospital. If you are a healthcare provider and you are giving your patients the risk of getting influenza from you because you're not vaccinated, you are an irresponsible dumbass. Everybody knows, or should know, well, you probably don't know if you're just a medical student. I shouldn't say just a medical student. If you're a medical student, you may be unaware that if you get influenza pneumonia, one of your big risks is developing secondary bacterial infections. This study looked retrospectively at influenza seasons and also found that there was an increased risk of invasive pneumococcal disease if you had RSV. So it looks like any number of viruses, if they damage your respiratory lining, will give you the risk for a bacterial secondary infection. I remember years ago my attending gave me an article on post-pneumonia pneumonia. I was a fellow at the time, and it was on how patients who get pneumonia are at risk for getting a secondary pneumonia. I've never been able to find that article since. But it makes sense that if you have damage from one bug, you're at risk for secondary infection with another bug. It was true with the H1N1 epidemic as well, where the incidence of invasive pneumococcal disease went up with the incidence of H1N1 in all groups, except, interestingly, the elderly, who probably had prior immunity from old influenza. But it was age 5 to 19 that had the biggest bump in invasive pneumococcal disease that coincided with the H1N1 outbreak. The multiple impacts of influenza on the human population, as well as the vaccine and immunity, is yet another reason why infectious diseases remains so fascinating. And I refer you again back to that New England Journal article I led the review with. What is the number 2 most commonly reported infectious disease in the United States? Gonorrhea. There are 600,000 cases a year. Somebody's been busy. The important thing to note, however, about gonorrhea is it is becoming resistant to all of our antibiotics. Currently, it's cephalosporins, which have been the mainstay of treating GC. Rates have gone for resistant organisms, or at least those whose MICs are greater than 0.25, which has been the cutoff, from 0.1% in 2006 to 1.7% in 2011. The rates have really gone up in the West, go West, from 0.2 to 3.6%, and especially in men who have sex with men, where it's gone from 0.2 to 4.7%. We already have quinolone resistance, doxycycline resistance, and macrolide resistance. So currently there's a race between Staph aureus and gonorrhea to be the first bacteria that we cannot kill. I'm going to put my money on Staph. The resistance in gonorrhea is through multiple mechanisms, both proteins that decrease binding of the cephalosporin to the penicillin binding protein, as well as a mutation in the porin that allows the cephalosporin to get in and do its work. It also has a DNA cassette. You'd think in this day and age it would have a DNA CD or even a DNA MP3, but it has a DNA cassette which has multiple resistance genes with it that they think came from commensal Neisseria species. It's all about exposure risk. There isn't much Lyme in the Great Pacific Northwest, but there is on the East Coast. This study looked at the distribution of ticks that can cause Lyme disease. There's one big cluster along the eastern seaboard that goes from about Maryland up through Maine and about looks to be maybe 100 miles inland. And then there's another big cluster in Wisconsin and northern Minnesota. And that's where most of the high-risk tick population is. There's a surrounding area of less common ticks, a transitional area, but large swaths of the United States are essentially tick-free for the spread of Lyme disease. And for instance, one place you're unlikely to get Lyme is if you live in urban Portland, Oregon. I always somewhat mistakenly think of this as an infectious disease podcast for people who practice in the United States, since that's where I do my medicine. But I try and remember to throw in the occasional tropical disease. When I was a kid, there was a restaurant in northeast Portland called Yaz. It was a burger joint. It had great burgers. And it wasn't until I got to medical school that I learned that Yaz was actually endemic treponematosis, a cousin of syphilis. It's a problem in South America and Papua New Guinea. This study compared oral azithromycin with IM penicillin for the treatment of Yaz and found the azithromycin in a single oral dose to be non-inferior to IM penicillin G. Obviously, it's much better for kids and in areas where they don't have the best health care not to give IM shots. Part of the spread of viral hepatitis in sub-Saharan Africa is thought due to the reuse of needles during vaccination programs, and in resource-poor areas, it would not be unusual to reuse IM penicillin needles. Therefore, having an oral drug that you could use once, like azithromycin, would be of great benefit in the eradication of Yaz in endemic areas. Northeast Portland's Yaz subsequently went out of business, and I still mourn its passing, although I will not mourn the passing of Yaz in tropical areas. My career has seen the decline of the duration of antibiotics for sinusitis from 14 to 10 to 7 to 3, and now probably 0. This study was published in the JAMA, and patients were randomized to receive either amoxicillin or placebo for the treatment of acute sinusitis. They were also given symptomatic relief with Tylenol, guanfacine, dextromethorphan, nasal sprays. And they found the outcomes were the same in both patients' populations. Whether they got an antibiotic or they got placebo, they all got better at the same rate, and they all had the same improvement in their quality of life, which they measured. Now, unfortunately, they did not do cultures, so you do not know if all these patients had infections that were due to resistant organisms, such as Moraxella haemophilus and Strep pneumoniae, the top 3 bugs frequently being resistant to amoxicillin. But this is not the first study to show that placebo is as good as antibiotics for the treatment of acute sinusitis. And it's nice to know that otolaryngologists have a sense of humor. to assess symptoms, they used the Sinonasal Outcome Test 16 or the SNOT 16. That's the kind of thing that obviously appeals to me. And in another study published in JAMA, 3 days of ciprofloxacin was compared to 3 days of cefpodoxime for the treatment of acute cystitis, and found, to my surprise, that Cipro was better than cefpodoxime by about 11%. 93% of the patients on Cipro were cured with 3 days versus 82% of those on cefpodoxime. I would have thought that either group would have been almost 100% cured, since urinary tract infections are fundamentally a self-limited disease, but it would appear at least that cefpodoxime should not be used in lieu of a quinolone if you can give a quinolone. And that would also wonder about whether or not, if you did treat somebody with cefpodoxime, if you go for a longer rather than a shorter course of therapy. Hey, I have an idea. Let's take a therapeutic intervention that has virtually no biologic plausibility. And what little biologic plausibility there is probably not applicable to care. Let's take an intervention that is pretty clear-cut, doesn't do diddly in adults. And hey, let's try it out in children. So they did a randomized placebo-controlled trial on cranberry juice for the prevention of recurrent UTIs in children, and guess what? Duh, it didn't work. The story of cranberry juice is the same as it is for other supplements, complementary, and alternative medicine therapies. That acronym is SCAM. And it doesn't work. And better done clinical trials show worse efficacy, until good clinical trials show no efficacy. That is the story of all, quote, alternative medicine, unquote. Not surprisingly, cranberry juice doesn't do diddly in kids, and why should it? It doesn't do diddly in adults. I have ranted at this at length over on my Quackcast, and I've written, I believe, an essay on it over at Science-Based Medicine. But, like all scams, it will never, ever die. And I, at least, wonder how they even got it through their IRB. And it's a good chance to transition smoothly into 2 studies about obesity. One study demonstrated that patients who are obese, BMI greater than 30, had a 2.5 times higher UTI incidence and a 5-fold higher pyelonephritis incidence. So it is not good to be obese for a lot of reasons, including increasing your risk for urinary tract infections. The other study out recently showed that patients who are obese are more likely to get the wrong dose of vancomycin for their MRSA infection, and that the more obese they are, the less accurate the initial dosing is. That also does not come as a surprise. We have protocols for the dosing of antibiotics in the obese in my hospital because we have a bariatric program, but it's still problematic in large people in trying to determine appropriate dosing, especially when it comes time to send patients home on oral therapy. Is 500 QID cephalexin sufficient for a 400-pound patient? I don't think so. You can give 1 gram comfortably. 2 grams orally QID? We really don't take the volume and distribution of the morbidly obese into consideration in treating outpatient oral therapy. And I'm not certain what the solution is, although I remember, if you're not part of the solution, you're part of the precipitate. Yeah, I know that was random, but what the hell, it's my podcast. Just a brief report of 2 kids who were treated with macrolides for the group A strep pharyngitis, both of whom went on to develop acute rheumatic fever. If you're going to treat group A strep, you should always give penicillin, in part to make people better a little faster, but it is still used to prevent acute rheumatic fever, and other agents are not as efficacious, and or there is too much resistance, such as macrolides. I know people have difficulty in giving penicillin, but it's still effective for streptococci. As I said before, the theory behind the meta-analysis is if you have several piles of cow manure and you collect them together, you get gold. Be that as it may, they do have their utilities. And this study looked at the use of hibiclins in the ICU to prevent infections. and found that in a meta-analysis of the available studies with only one randomized controlled trial, that it was indeed beneficial in preventing bloodstream and other infections in the ICU. One of the things that's never certain in these types of studies is how well people are adhering with other procedures to prevent infections, the so-called skip procedures, for example, for the prevention of surgical infections, or the bundles for preventing UTIs and line infections. When you rely on an antimicrobial, you will eventually get resistance. And there was one study that suggested that the use of Hibiclins increased the rates of spread of staph in the ICU because they had a Hibiclins-resistant organism and everybody got dermatitis from the Hibiclins. So no good deed ever goes unpunished in medicine. And if you're resorting to antibiotics to try and prevent your infections in your institution, the odds are very high that you could improve, this is personal opinion, you could improve your basic techniques to decrease infections in your hospitals. And antibiotics, even a topical one such as Hibiclins, are usually the wrong answer if you have a problem. The problem is probably your hand washing adherence is horse shit. Now that can't be true, is it? Now, the next study, again, concerns MRSA in the ICU. However, this one is who develops endocarditis. They looked at all their Staph aureus bacteremias in the ICU and found that 12% developed endocarditis, and that if the MIC was greater than 2, 5% developed endocarditis. They found the risk factors for developing ICU endocarditis were, of course, care in the ICU, having heart failure, and having a primary bacteremia or an infection due to an intravascular device, as opposed to cellulitis. If patients had heart failure, primary bacteremia, and an MIC greater than 2, the risk for endocarditis was 2/3. They had none of the above, it was 0. It's interesting that the higher MIC was associated with the development of endocarditis. I would wonder if it's because the use of agents to treat the primary bacteremia were ineffective for the prevention of endocarditis, and that there was actually more endocarditis than you suspect, but prompt early antibiotics eradicated it in people who had a lower MIC. I don't know if that's the case or not, but certainly if a patient has an MIC greater than 1.5, my inclination is to give something other than vancomycin. It also gets to the issue that endocarditis is common in patients who have bacteremia due to Staph aureus, especially hospital-acquired bacteremia, and they should be looked at aggressively for endocarditis and treated accordingly. What are you going to use for MRSA? I don't know. I mean, is there a bat? Nope, still no bat. I'm going to worry about that all day. This was a salvage study. They looked back at their ceftaroline patients, those who had endocarditis or bacteremia not responding to standard antibiotics, in this case vancomycin and daptomycin, and they found that all 6 patients got better when switched to ceftaroline. Although one did require valve replacement, the valve was sterile in the OR. So I still wish that we'd have a trial of ceftaroline in the treatment of endocarditis and bacteremia rather than the piddly shit studies we have with community-acquired pneumonia and cellulitis. It's just aggravating that a drug that you need proof for serious infections gets approved for piddly infections for which we have a sufficiency of therapies. But yes, I know, it was the easy thing for the pharmaceutical company to do. Well, you don't know this, but I've been off to breakfast at Pig and a Pancake and come back and still no bat. This is going to be the Bat Podcast. Now, the next article up on our hit parade of bat-free articles is the use of daptomycin for cardiac implantable infections. So you put a pacer or a defibrillator in someone and it gets infected. Well, they had 25 cases of endocarditis due to staphylococci that were treated with daptomycin, and they had a good outcome. They cured the vast majority of the patients, 92%. There were 2 patients in whom they did not take out the pacer wires. One survived with the cure, one died, which is what you'd expect if you don't take out the hardware. But basically, in an unenthusiastic trial, they removed the hardware for pacer-associated endocarditis, and they were mostly cured. They also used, by the way, relatively high-dose daptomycin on order of 8 milligrams per kilogram per day up to 10 milligrams per kilogram per day rather than the standard 6. People keep pushing the daptomycin dosing to treat these infections, and whether that's useful or not is still uncertain, but more is always better, right? That's certainly true with ice cream, it's true with beer, and it's probably true with some antibiotics. Some gastroenteritis news, as it were. There was an outbreak of salmonella that affected 132 cases, mostly kids, that were associated with small turtles. I did not know this, but there's a 30-year ban on small turtles that was ignored. They sold these out of Louisiana. And as they mentioned, small turtles tend to be used by kids as toys and put in their mouths. Who put a small turtle in their mouth? Well, kids do. And they all got Salmonella enteritica serotype paratyphi B variation L. So be careful what you put in your mouth, especially if it's a small turtle. You'll be happy to know that since they've been controlling Campylobacter in New Zealand, they've seen a steady decline in the rates of Guillain-Barré syndrome. You like the French when I do that? But GBS is always been associated with a post-infectious complication of Campylobacter enteritis. And in New Zealand, they have declined the rates of Campylobacter by 52%, he says, with a complete lack of grammar. And subsequently, their GBS has fallen by 13%. So, benefit there. And then if you don't want to eat turtles and you'd rather eat venison, be careful. There was an outbreak of Shiga toxin-producing E. coli in Minnesota, where they all ate undercooked venison and did not wash their hands properly. It's amazing the things people do with their mouths. Nothing beats the castration of sheep with their teeth, which led to Campylobacter, which I talked about earlier. But I suppose putting a turtle in your mouth or raw venison is almost the same as castrating a sheep in terms of cleanliness. Ugh. Little diagnostic pearl here. At least the study took blood culture bottles and they inoculated them with Candida and either Staph or E. coli as well, and found that the bacteria masked the candidemia, or at least the ability to isolate Candida in the blood culture bottles. So they suggest maybe you want to use fungal isolators if you're worried about candidemia in the right clinical setting. I'm not certain that's necessary all the time, but certainly patients can have polymicrobial bacteremia that may be masking the candidemia. It's hard to say how often that happens practically. I think that ends it. There's an article that 5% of people with Giardia develop post-infectious chronic fatigue syndrome. That's the last article in my queue of things I wanted to talk about. So as we reach the 33rd minute, I can tell you that there are no bats yet seen. It will probably come out tonight while I'm quietly reading. Bats. That ends the podcast, the Puscast, in fact, for the first 2 weeks of February 2012. No more CME. This is brought to you by Pusware LLC, where you can find my books, my blogs, my podcasts, and my blood type at moremark.squarespace.com. Just remember that my book, The Pus Whisperer, is available for a mere 99 cents on Amazon. Yes, 99 cents. I'm having my 99-cent sale. It's going to be 99 cents until the temperature reaches 99 in Portland. And as I've mentioned, I've yet to decide if that's going to be centigrade or Fahrenheit. As always, don't forget to go on iTunes and write me glowing reviews to feed my ravenous yet fragile ego. This is copyright 2012 under the Creative Commons license. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.